Thank you and good morning. Cataract and diabetic macular edema are conditions which could coexist. A patient with diabetes mellitus could have a diabetic retinopathy, and many of these individuals could have a macular edema. It is a well-known fact that cataract progresses faster in a diabetic patient, and hence these two conditions could coexist, and management of these two are interrelated. What are the concerns to be addressed when we are dealing with a patient with cataract as well as a diabetic macular edema? One is, does the cataract affect the progression of DME? Does the cataract affect the management of DME? Does diabetic retinopathy affect the progression of cataract? Does diabetic retinopathy affect the management of cataract? Does the management of cataract affect the progression of diabetic macular edema? And vice versa? How do we manage a coexisting cataract and a diabetic macular edema? Are there any precautions to be taken while doing cataract surgery in a patient with diabetic retinopathy or a DME? And when you have to combine with a vitrectomy, when and how? So these are the questions to be answered, and I'll run through this quickly in the time allotted. Does cataract affect the management of diabetic retinopathy? Cataract at times is a hindrance to diagnosis of diabetic retinopathy because of the poor visibility of the fundus. It might be that we don't get a good FFA or an OCT picture. We might miss a diabetic macular edema or a neovascularization of the disc or an NVE. And left untreated, these are conditions which might go into a permanent visual loss. Hence, a diagnosis of the underlying condition, it's most important but at times difficult. These are some of the FFA and OCT pictures which we might get when there is a coexisting cataract and a DME. Diabetic retinopathy and diabetic macular edema per se may not affect the management of cataract, but certain precautions are needed while doing a cataract surgery in a patient with a coexisting DME. While preparing a patient for a cataract surgery, we have to do a good slit lamp and a fundus examination depending on the stage of the cataract. A pre-op OCT is helpful in documenting any possible increase in DME following cataract surgery. Many a time we might be seeing the DME for the first time after the cataract surgery, and we are not very sure whether this has been there prior to the cataract surgery or not. A diabetic patient might have a non-dilating pupil. The surgeon should be aware of this problem. If you have a posterior capsular dehiscence during cataract surgery, that might cause an increase in DME. Conventionally, silicone IOLs are not used in patients with diabetic retinopathy, and always take the help of an experienced cataract surgeon when you are managing a patient with a coexisting DME. If you get such a fundus picture, when you take up a patient for cataract surgery, always manage the diabetic macular edema before you take up for a cataract. About diabetic retinopathy and progression of the cataract, diabetic retinopathy as such does not affect the progression of cataract. However, nearly 2/3 of diabetic population show evidence of cataract, and the prevalence of diabetic retinopathy was 18% in an urban population with diabetes in India. So that means these are two conditions which could coexist. In type 2 diabetes, individuals who have type 2 diabetes mellitus at an early age were more likely to develop both cataract and DR. And a strong positive association was observed between the fasting plasma glucose level, the duration of diabetes, and the risk of retinopathy and cataract. Does cataract surgery cause an increase in diabetic macular edema? The classical teaching is that cataract surgery usually results in an increase in DME. However, the ETDRS report number 25 doesn't support that. It's probably because of more intensive photocoagulation for diabetic retinopathy following cataract surgery. It's that when there is cataract surgery and the diabetic macular edema is managed immediately following that, there were good results. The flip side is cataract surgery can have improved visual acuity by an average of 2 lines for patients both with and without diabetes, but no past laser treatment, and no significant visual acuity improvement was evident in patients who had a preoperative laser for diabetic macular edema. But from the ETDRS days and laser photocoagulation, we have come to the anti-VEGF era where we have a better outcome. Progression of cataract, post-DME management, laser photocoagulation and intravitreal anti-VEGF agents do not affect the progression of cataract. However, intravitreal triamcinolone might hasten the progression of cataract, and an iatrogenic lens injury might cause a progression of cataract. So these are conditions which we have to look for when we are treating a patient with a coexisting DME and cataract before taking up for cataract surgery, anti-VEGF is preferred over steroids. When cataract and DME coexist, manage the DME immediately followed by cataract surgery. As I said, anti-VEGF is preferred over steroids, and panretinal photocoagulation cataract surgery were performed which had no effect on postoperative retinopathy. The BCVA was in fact better in the group which had the surgery first. Anti-VEGF versus steroids, this was a head-to-head trial between Avastin and Tricort. When administered at the time of cataract surgery in patients, Tricort in fact had a better visual outcome. Both had an equal visual outcome, but Tricort had a longer lasting effect. DME and postoperative visual recovery. Macular edema before surgery is the most common condition that limits postoperative visual recovery. Thus, preoperative anti-VEGF treatment is required. A combination of anti-VEGF and laser could be considered. About diabetes and visual recovery, diabetes eyes have a high incidence of increased center point thickness on OCT after cataract surgery. That is, in non-center involving DMEs following cataract surgery, there could be an involvement of the center. Hence, a preoperative OCT is always advisable where you can compare it with a postoperative OCT. Macular edema after cataract surgery in eyes without preoperative center involving DME, yes, the non-center involving DME could progress to a center involving DME. Now the next question, I'll end up very soon. Anti-VEGF, should it be given preoperatively or intraoperatively? In fact, the peak action of anti-VEGF is within 24 hours after the injection, and the half-life lasts for 9 days. So I would prefer a preoperative anti-VEGF than an intraoperative anti-VEGF. Moreover, if we are giving a preoperative anti-VEGF, that is in my settings and not in the cataract surgeon's settings. This is the impact of cataract surgery during treatment with Ranibizumab. In patients undergoing Ranibizumab treatment for DME and who had cataract surgery, an average of 2 lines of vision were gained from the last visit before surgery to 1 month following surgery. Phaco can be done combined with a vitreous surgery. Again, it's a surgeon's choice and the setting within your operating room. So the bottom line is, treat the diabetic retinopathy adequately as far as possible, inject, do the cataract surgery, evaluate, and then inject or laser as the case may be. Anti-VEGF may be a good choice prior to cataract surgery in patients with DME. Post-operatively, you can have anti-VEGF or steroids. Cataract surgery, especially phacoemulsification, is a safe procedure in patients with diabetic retinopathy, and phaco can be combined with a vitrectomy.